Dr. Jonathan Tripp, battling not just illness this morning, but he's battling transportation. That is a train.
Yeah, no, it's this is proof that even people on the radio have normal lives and get stuck. I was almost here coming down Blue Lakes and ran into a very slow but not too long a train, and so I'm sitting behind it thinking I'm the very first one at the intersection, ready to go for the green light, and all of a sudden the lights for the railroad crossing start, and the train starts to come to the intersection. So I'm slowly watching this, run through a series of lights. I'm still sitting there. Train is almost through, and I'm thinking, okay, it's relatively short. We're just going to stay right here. And by the time I try to go to another intersection, I'm going to be stuck there. So I'm just waiting. The train stops. So I wait a little longer. And then the train starts going backwards. And so I decided to take a long, different route. So here I am. It's a little later than usual, but I've got a fun topic that you've already been talking about.
People and everybody knows this topic. Everybody, I don't care. Even young people occasionally feel the joint pain.
Yeah, no. So joint pain, tendonitis, what's called bursitis. So these are places that I'll just call them owies because that's the sophisticated type of terminology we use in my office. But places like your elbow, they talk about tennis elbow or golf elbow, your shoulder. We have several kinds of tendonitis or bursitis there. The knee pain, interior knee pain, and then exterior knee pain. So there are places that we use steroid injections pretty regularly. The hip, most people think of their hip as the part that sticks out when you stick your rear end to one side. That it's really not truly the hip; it's part of your femur, but there's a bursitis there that gives a lot of people trouble. That often steroid injections are a nice relief. Let me preface everything I'm saying by at my office, people will think I don't know anything at first because I talk about ice, ice, and ice, especially on a new injury like a sprained ankle or these tendonitis or bursitis conditions. I am nearly 100% of the time telling people I need you to ice this 2 to 3 times a day, 10 to 15 minutes at a time till the bone feels cold for a week or two before we'll consider one of these injections because there are some risks with the steroid injections. And I'm going to go through that later in this discussion. But then I also want to talk about what's on the new, what's coming up, what are some alternatives, and some really exciting stuff that has I have a lot of interest in and probably will be doing very soon in our office as we've been investigating some of these new uh, techniques, some really promising things.
And again, we're thinking about this being done. I mentioned people have problems anywhere, all the way out to your knuckles, but ankles, hips, and knees you've mentioned. Uh, it's not a be all end all, but it certainly can help people out a great deal.
Well, I tell you what, sometimes it's like a miracle. Um, and I got to be careful because there is a downside to steroid injections. But let me tell you the good news first, and I'll give some examples. I have a lady who, we don't think of the 60 plus crowd being the intensive texters, but she's a two thumb texter all the time, all day long. And twice over about a year period, I had to inject her thumbs at the very base of the thumb, because she had irritated them so much by texting. So what's the better answer? Call people. Stop texting so much. But the truth is she did slow down because it hurt. And once we iced for a while, and then we went, that did improve it, but not enough. And so the steroid injections became to her like little miracles. And I'm confident that she went back to texting. So that's one. Another example is a younger man, 35-ish, had a tendonitis in the front of his shoulder. So when he lifted his arm forward or had to drive the car holding the steering wheel, have a lot of tenderness there. Um, in fact, he's a race car driver, actually, a dirt track race car driver. This is in Texas, and gave him that shot along the tendon, and just within 2 days, like a miracle, all things cleared up. And he had great success one time, and then the second time he didn't have such good success because he came back about He said that it lasted for about a week to 10 days, and but it didn't last any longer than that. So, having had such good success before, I asked him, "Did you do anything differently?" And he says, "Well, I went out and chopped a cord of wood." And I said, "Do you normally do stuff like that?" He says, "No, but it felt so good." So sometimes overdoing it just because it feels good kind of reverses the whole effect.
But you almost have to have somebody who's got chronic issue. I have a thumb here on my right hand, and it occasionally hurts at the base, and but it's not frequent. And I think it is related to when I was playing football, I dislocated it on the field, but I popped it back in on my own going to the sidelines and never had anybody look at it. But it's been fine. I can still use it. But every once in a great while, I feel that a sharp pain through there. But because I don't feel it all the time, I wouldn't really be a candidate for an injection, I would imagine.
I would try to dissuade you from doing that, um, especially if I can talk you back into those moments where it hurts. If it hurts for a day or two, let's try ice, see if we can get that calmed down again. If it starts becoming more persistent, yeah, then a steroid would probably be a great choice.
Right, but it would have to be a very regular.
Or,
Uh,
or just something that, lasted, if it normally lasts for a day or two and now it's lasting for a week or two or a month, then we sure could talk about that because it's probably progressively getting worse. It's probably a true arthritis, meaning a deterioration somewhat of the actual joint that's happening over time with wear and tear and maybe initiated by an injury, like you say, a long time ago.
Now, for people who are actually taking these injections, what's the downside?
Okay, let me talk about downsides. Um, the single most common one that actually shows up is if the steroid actually leaches or leaks up into the fat that's just underlying the skin. It'll shrink that fat. So a lot of people say, well, that's a good thing. I want to get rid of much fat as I can. The problem is that shrinkage is in a very specific area. Almost looks like somebody put a thumbprint in your skin, and the skin looks okay, but you now have this dent where it was. So that's probably the most common, but it is truly only a cosmetic issue, and sometimes that resolves itself, and other times you get that thumbprint that stays permanently. Um, that's one. The more serious kinds of things are you can get joint infection if you're going into a joint because you're using a needle, not just because of the steroid. If you because you're using a needle again, you can get nerve damage. We talked about the fat thinning and the skin thinning. Um, you can get a temporary flare of the pain. In other words, the day after this shot, it may be worse than it was before, but usually within a day or two following that flare, life gets pretty good with these. It may not work. That's probably, I should have started with that. That's probably the most common. You get this injection that you got great hopes for, and it either doesn't work at all or it works for a week and then it's right back to where you were and you say, well, that didn't help me a whole lot. So it is a little bit of trial and error with that. More serious trouble is damage to the tendon itself or decreased. We are concerned about. There's a belief. There isn't a lot of proof yet, but there's a pretty strong belief that repeated injections will cause thinning or destruction of the cartilage in a joint. So one or two here and there, that's okay. There's even some evidence to suggest that there's some crystals left around from the steroid, and so that crystal now becomes an irritant to the joint. But again, my take on that would be less is better. The recommendation is no sooner than 6 weeks between shots, and really recommended is probably about 3 or 4 times a year at most. But what I find is most patients need it once. They don't need it, ongoing. And if they do, it's time to find another method to treat that, and sometimes that includes surgery. So this is a temporary treatment to try to get you over the hump of the current inflammation and see if you can strengthen the joint, make it better on your own. But the one that is the scariest is when we're involving tendons, is that it can weaken the actual tendon and you could have tendon rupture. Um, I've never had it in my practice. I think a big part of that is you have to actually inject into the tendon to cause more direct problems. And the tendon is very tough. It's a really hard thing to inject into. I give patients the analogy if I stuck a needle in a piece of drywall and then tried to inject whatever I had that's about what it feels like. So unless you're really forcing it, you don't inject into the tendon. You want to be next to it. But even that, there may be some real risk of tendon weakening. So that's the downside. The good news is steroids suppress inflammation. They don't care why. So if you have swelling, and it's a rash on your arm, we put a steroid, cortisone, on there. If you have gout, we will often give you pills, oral steroids, or it could be an injection into the joint, although most physicians I know just use a pill. And it suppresses the swelling in your entire body. So a lot of people get that, 10-day dose of steroids and want to continue because they feel so good. Everything stops aching. But long-term use of steroids can cause you all kinds of troubles with your organs and redistribution of fat. So short-term, small dose steroids are usually a pretty beautiful thing.
We referenced inflammation, and I have read that there are a lot of medical people who say that people who experience inflammation are going to have some medical issues down the road from that. And so we try to reduce inflammation as much as we can because it can have some long term cardiac aspects, as I understand it. So the trade off might be you're better off with the injections than the inflammation.
Tough call because when we think about those inflammatory markers, we're talking about general body inflammation. So if somebody says, "Hey, you have a knee that's in trouble," I wouldn't relate that so much to heart attack or stroke down the road. Um, However, it will decrease your activity level, which makes total sense that your overall health will decrease because you just feel like I can't do this, I can't get around, so I slow down, I eat more, and all those things kind of cascade into bad, body health. But you're right, there are some markers that we talk about, just general inflammation that show up in the bloodstream that give us a hint that hey, there's something going on that we need to decrease inflammation in general. Maybe the joints are part of that. I don't want to make a direct connection between that and heart disease. It's possible. It is definitely possible. I just am not aware that we've made that kind of a direct conclusion between joint inflammation and heart disease.
And a lot of this too is related to where it's at. I'm sure I have a friend and she's planning on retiring from nursing in December. So she's got just a few months to go, but she's now getting because of arthritis. She thought she had a stenosis in her spine. Turns out that the main diagnosis was arthritis. So now she's going and getting injections in her lower back, and this will keep her going through the end of her working life, and then she'll be able to retire. But I imagine that at some point she's going to have to still have injections even after retirement, even though she won't be working on her feet 8 to 15, 16 hours a day.
Yeah, the steroid. These are also steroid injections, and they are done by guidance of what's called fluoroscopy. It's like a moving X-ray. And so the whoever's giving the injection is actually watching the needle approach the spinal cord, and so it is right in between the bones of the spine or along the nerves that are exiting the spine. So these are some very cool or sophisticated uses of steroids. And again, for some people they are a miracle, and other people they don't work for at all, and they go through the pain and the minor trauma of the injection and the cost and don't have any good results. So they're not a panacea. And so sometimes surgery is indicated, and I'm slow to send people to surgery. I'd much rather do physical therapy, do some steroid injections, other conservative measures, and now with the joints in particular and tendons, we have some very cool new stuff that uh, one of which is not really new. It's the main ingredient is called hyaluronic acid, and hyaluronic acid has all kinds of uses from cosmetic to joints, um, all kinds of fun things. But what it basically is a molecule that acts like a sponge. And this is a sponge that holds, I can't remember exactly, but it's like 100 times its weight in water. And so it is an incredible little molecule, and it's primarily in our cartilage. And so this is something that keeps moisture, keeps lubrication in places where we need it. In fact, I was just reading a study done 2013, and it's called the Journal of Anatomy, where they were looking at the plantar fascia. So people talk about heel spurs or this pain on the bottom of the foot, which is another place we put steroid injections. And they were saying that the tissue of uh, the fascia in that area produces an unusual amount of hyaluronic acid. And so their uh, hypothesis is that instead of using steroids in that area, it might be more appropriate to inject hyaluronic acid, something that's already produced by that tissue, and might improve the healing much more efficiently without the risks. So that's kind of a really fun thing. We use hyaluronic acid for knees, and it is kind of the last step before a knee uh, replacement, but it is essentially replacing the knee fluid with a lubricant. We don't have grease nipples on our joints that we can just use a grease gun, but this is probably the closest that we have so far to being able to do that.
We've got to take a break, but for people who'd like to get in touch with you at the office, a number of ways to do that.
Yeah, our telephone number is 208, and I think everybody has to use 208 now. 208 933 4400. That's 933 4400. You can reach us on the web at trippfamilymedicine.com and also on Facebook at Tripp Family Medicine.
We'll be picking this subject up again in a few weeks to expand upon it, too. We wanted to mention that.
We're going to talk about a really, really new and cool thing called platelet rich plasma, or PRP. This is cutting edge stuff, not approved by the FDA, for, at least, let me say it this way, insurances won't pay for it. It is approved by the FDA.
We've got more coming up with Top Story in just a few minutes. Jeanette Rowe from the Twin Falls Senior Center will be joining us in just a few minutes. But first, we'll have a news update from Fox at 9 o'clock.